Let's get started here. So welcome everyone. I'm Kim Workmeister. I'm the Senior Vice President for Improvement and Implementation for Convergence. I'm thrilled to have you all here today as our kickoff for our series that we are planning for the next several months to cover this new CMS patient safety structural measure. There has already been quite a bit of enthusiasm for this, quite a bit of questions. We've held a couple of listening sessions already with a few folks that we knew just to hear, what are folks thinking about this and how is this sitting with folks? How challenging is this going to be for them? And so I wanted to start with just a little bit of information here before we get going. So first of all, first and foremost, housekeeping. We're going to share the slides and recording with all registrants within a few days. This is the first of several planned collaborative learning session events that have not yet been scheduled, and we'll get to that in just a moment. It's because this is what Convergence likes to call a choose your own adventure type of series here. So at Convergence Health, we really do listen first. That is most important to us, everyone in healthcare that we are working with, to surface the challenges that you are experiencing right now and the bright spots. And then we co-design that practical pathway to tackling those challenges. So that means that your input is extremely valuable. And so we're going to get to that in just a moment. But first, I wanted to introduce our speaker today. I am so thrilled. And unfortunately, her full bio is now hidden from my view on my slides here. But that's what happens. But I think I can do a good enough job here too. I am just so grateful that Dr. Michelle Schreiber, who is the Deputy Director for Center for Clinical Standards and Quality, Director of the Quality Measurement and Value-Based Incentives Group from CMS, is joining us today. She is volunteering her time, and we are so appreciative. Many of you already know that Dr. Schreiber is deeply, deeply involved in leading the efforts at CMS when it comes to things like value-based care, when it comes to equity, when it comes to all of the patient safety related activities that we are engaged in. She knows this work well. She has been a practicing physician in clinical practice for more than 2 decades and is just a wonderful, wonderful champion for patient safety. And so thrilled to have her here. But let's get to what we all came here for today, too. So I am going to turn it over now to Dr. Schreiber. Dr. Schreiber, feel free to just let us know next slide, and we will get through with this. So the floor is yours.
So Kim, thank you very much, and thank you for the invitation to be here today. If people can't hear, just let me know in chat, please. I'm really very excited about this, and I'm very excited about your participation and your enthusiasm about this measure. I'm happy to answer questions to the best of my ability. As Kim already pointed out, I am a primary care physician by background. I've worked in large healthcare systems for a very long time. I've been a chief medical officer, a chief quality officer in several systems. I've worked at local, state, national levels to advance healthcare quality and safety, and came to CMS about 6 years ago in the first Trump administration. We're obviously preparing for the second Trump administration. And we're really very excited to bring forward this measure around such an important topic of patient safety. I know some of you asked questions that you've submitted in advance. So what happens with the new administration? Obviously, we can't answer that right now, but I will say during the first Trump administration, patient safety is a bipartisan issue. It crosses both sides of the aisle. Congressional members from both sides have been very interested in this. Patient safety is a fundamental issue of healthcare, and we know that there are issues in patient safety, and we have seen all sides really be very interested in it, again, including in the Trump administration and in the Biden administration. So we're expecting that we will continue a focus on patient safety moving forward. Next slide. Let's see if you guys can advance this. There we go. No, back. So today's back. There we go, right here. So today's agenda, obviously, we're going to talk about the patient safety structural measure, increase awareness about this measure, understand the link of why we used a structural measure and why that's important in safety, and translate this into actions that hopefully you can take in your organization. Next slide. I don't know if there's a lag. I'm waiting for the slide to come up on the screen so that we're all on the same page. There we go. Why is this important? I think all of you can answer this question really, but even 20 years ago, it's almost 25 years now, To Err is Human, Crossing the Quality Chasm, pointed out the real issues of patient safety in healthcare. As recently as 2018, data from the Office of the Inspector General shows that still 1 in 4 Medicare beneficiaries experiences harm. We know that there are ongoing issues in safety, despite the fact that we have tried very hard and have indeed made improvements since those Institute of Medicine reports several decades ago. But we also know that during COVID, the safety and quality performance metrics of the country really took a nosedive. There's lots of reasons for that, but one of the underlying reasons is that our systems that support safety weren't sustainable. The staffing wasn't sustainable. Many of the sort of operational pieces and processes that it takes to support safety either weren't there or they weren't sustainable during the time of COVID. It certainly wasn't for lack of people not putting in efforts from the frontline workforce, but systems of safety need to be robust and resilient so that we always maintain patient safety. Between 2010 and 2019, we really did see a lot of improvements. There are publications that are referred to here, particularly around healthcare-acquired infections, for example, some of the chronic diseases, right, around heart failure, pneumonia, major surgical procedures. But again, there has been a ways to go. And during the pandemic, I spoke about that already. There have been many recent coordinated efforts around patient safety, and we can touch on those in a moment. But in particular, I want to reference the National Action Alliance for Patient and Workforce Safety, which was really put together by the National Steering Committee from the Institute for Healthcare Improvement, as well as AHRQ. There are a number of people on the National Steering Committee, myself included, who put together a document of the National Action Alliance for Patient and Workforce Safety. And if you aren't familiar with it, I would encourage you to take a look at it for several reasons. Number one, it has a self-assessment that I think would be very helpful for the patient safety structural measure and helpful for any organization to assess where they are on the safety journey. And two, it has a lot of best practices there. In the past year or so as well, the President's Council of Advisors on Science and Technology have recommended to all the federal agencies that we develop a list of high priority harms and system level mitigation strategies to eliminate preventable harms. That report from what's known as PCAST is available, and the link is here in the slide. So referring to those, you can see that there's been action across the federal government at the highest levels, including up to the White House, the President's Council of Advisors on Science and Technology, up to the White House, to try and address patient safety with a goal of zero harm, recognizing we will probably never get to zero harm, but we should never stop aspiring to zero harm. And there are a lot of resources that are available now. Next slide. There is cause for optimism. According to recent CDC data, as well as recent CMS data, we are starting to see a trend of improvement back to pre-COVID data levels. Again, not that that was where we want to be, but it is trending better from where we were during COVID. So since the end of the pandemic, we have seen a continued decrease in CLABSI, a decrease in CAUTI, both in regular floors and in intensive care units, a decrease in ventilator-acquired infections, not a significant change in surgical site infections, but a decrease in hospital onset methicillin-resistant Staph aureus, a decrease in C. difficile. There really haven't been a lot of changes in the long-term care facilities, but we are starting to make progress, and that's very good news. But we also know that we need to not only continue to make more progress to get back to pre-pandemic levels, but to continue always again with the goal of zero harm. Next slide, please. So the patient safety structural measure was developed by CMS. When CMS develops a measure, we do it with a technical expert panel. So there was a significant technical expert panel that included a number of patients and patient advocates, as well as experts in patient safety in the field. This measure was finalized for use in acute care hospitals, as well as the cancer exempt hospitals. So the 11 freestanding cancer hospitals of the country, like MD Anderson, Memorial Sloan Kettering. And this was finalized in the 2025 inpatient payment final rule. In other words, just this past year. It does exclude Children's Hospital. It excludes inpatient psychiatric hospitals. It excludes long-term care or rehab hospitals. And there were a number of questions of, do critical access hospitals have to report this? The answer is no. Critical access hospitals have a choice of reporting measures that may be in the hospital inpatient quality reporting program, but they don't have to. They can do it voluntarily. There is no penalty for not reporting. The only time critical access hospitals have to report measures that are, most of the measures in the hospital inpatient programs is when they are part of promoting interoperability. This measure is not part of the promoting interoperability program, and so is not mandatory for critical access hospitals. The reporting of this begins in January. In other words, in a few weeks. And your report will be due back probably around March of 2026. It's usually in the spring the following year. So as you respond, it should really be a response that reflects your performance during the year 2025. You don't necessarily have to have everything in place for the entire year. If you have started some of these programs and you have them up and running, that would be certainly acceptable as well. But it does reflect calendar year 2025 from January 1st till the end of 2025. The first reporting, as I noted, will be in spring of 26, and the reporting is through the Centers for Disease Control, their NHSN, so the same place that you're reporting like your hospital-acquired infections. If you don't report at all, you will face a reduction in your annual payment update beginning in 2027. So it doesn't matter, even if your result is 0%, you still need to report. It is failure to report that would cause a penalty. It is not dependent on how you perform. This is a structural attestation measure, so it's meant to really be a conversation across your hospital about whether or not you have enacted the statements that are there, and to ensure that the structural components that underpin a robust and resilient safety program and operational policies and practices that support patient safety are in place. This is evidence-based. There was a long environmental review. The guidance document is very well referenced. I noted already that there was a technical panel of real experts in patient safety who put this together. And there's a link both here and in my last slide of all of the specifications for this, as well as the guidance documents that have been put out surrounding this measure. So there is a fair amount of information as well. Forgive me. Okay, next slide. The quality measures for harm are concentrated largely in hospital settings. Healthcare acquired infections, complications, the electronic clinical quality measures, hopefully you've noticed those as well, But we know that there are other areas in the future as well that CMS and others are starting to turn their attention to, like diagnostic error. And we also know that we need to be spreading, looking at safety, not just in hospital settings, but across the entire healthcare continuum. This is a beginning of making sure that the underlying operational processes are in place, and this evaluates organizational and operational actions to improve quality and safety. So it's different than your traditional outcomes or process measures, but structural measures can really impact behaviors of organizations. Next slide. I spoke of earlier, this aligns with a lot of work that is going on across the country. The American Hospital Association has been working on patient safety. The Institute for Healthcare Improvement for a long time has been working on patient safety. I spoke of the National Action Plan. This is information about this. This is their cover sheet. Again, if you're not familiar with it, I think it is very worthwhile taking a look at it, because the patient safety structural measure really was pegged off of this Safer Together National Action Plan to advance patient safety. And you'll see many things that are familiar across both. The Safer Together guideline includes a leadership commitment to eliminating harm, the strategic planning and organizational policy, culture of safety, and really becoming a learning health system around safety, accountability and transparency, and patient and family engagements. These topics were not chosen at random, but they really dovetail in with the National Action Plan, again, from IHI and AHRQ and the National Steering Committee. Next. So let's talk about a little bit what is actually in these domains. And you got a taste of that by trying to answer those questions and kind of feel out for where your organization is. So let's go domain by domain. As you know, there are 5 domains, and you answer each of the attestations, yes or no, in the domain. The way this is scored is that there's 1 point for each domain. So this domain 1 would have 1 point, and in order to get that point, you have to attest that you're doing everything here. So in order to get the point on domain 1 for leadership commitment to eliminating harm, you would have to do the following. Your senior governing board, I'm going to circle back to that in a moment, prioritizes safety as a core value and holds hospital leadership accountable for patient safety. That includes in the performance evaluations of senior leadership. You know, the board is responsible for evaluations of senior leadership. That those evaluations include patient safety metrics, and that informs board reviews. When I talk about senior governing board, we are very specific about senior governing board. I've been in many organizations who have a board of trustees quality committee, and that is wonderful. I think those are terrific. It's an opportunity to really do deep dives into quality and safety, but that is not what we are talking about here. It is the most senior board that has the fiduciary responsibility for the hospital that really needs to be involved in setting the tone and the resources and the support for patient safety. So you can have a subcommittee of the board for patient safety that reports to the board, but it is the board itself that really has to have responsibility in doing the actions that were talked about here. Leaders place patient safety as a core institutional value. So many people develop their strategic plans. They outline what their true north is. Patient safety should be part of that true north, and 1 or more C-suite leaders should be overseeing a system-wide assessment on safety, the execution of patient safety initiatives and operations, and making sure that there are improvement plans and metrics, and that those are shared, again, with the governing board. The governing board, in collaboration with leadership, needs to ensure that there are resources to support patient safety, and those resources can be driven by the needs of your organization, equipment, training, systems, personnel, technology, but it is the board that really directs resources in any organization. Reporting on patient safety and workforce events, including event cause analysis, infection outbreaks, many different topics. Reporting on this becomes at least 20% of the regular board agenda. That ensures that it's not just your subcommittee of the board that reports in a consensus agenda of 2 minutes to the board on patient safety, but that the governing board with the fiduciary responsibility is really committed and spending time on their board agenda talking about patient safety. And finally, we want to ensure that members of the board and the C-suite leaders are notified of significant adverse events. This is within 3 business days of a confirmed, so you have time to confirm these, a confirmed serious safety event that has resulted in significant morbidity, mortality, or other harm. Next slide. Slide 2. So the first slide really focuses on governance because we think that governance really helps drive what an organization focuses on. And the support of leadership is just fundamental in ensuring that we are focused on safety. The second is making sure that there's strategic planning and organizational policy that supports safety. This is that a hospital has a strategic plan that is publicly shared. That can be as simple as posting it on your website. Publicly shares its commitment to patient safety as a core value, and it outlines your specific patient safety goals, including we have an overall goal of 0 preventable harm. But as I said, we may never achieve that goal, but it is always our aspirational goal. Safety goals include the use of metrics to identify and address disparities. You define the disparities. Every community is different in terms of who's your vulnerable population, who needs help the most, what are populations that seem to have more adverse events. So you define the disparities and work on your plans to address them. Again, based on patient characteristics that are determined by the hospital to be most important in healthcare outcomes for the populations that you serve. There are implemented written policies and protocols to cultivate a just culture. So many of us are familiar with just culture that balances blame, no blame, appropriate accountability, and it reflects the distinction between human error or at-risk behavior and reckless behavior. And there are algorithms, that are widely available that outline how you really think of a just culture. If a significant error occurs, what's the framework of determining was it really a system issue? And most errors are system issues. They're certainly rarely the result of a person who comes into work going, I think I want to cause harm today. Frontline staff that's not why any of us came into healthcare. You have implemented written policies and protocols around cultivating a just culture. This requires implementation of a patient safety curriculum and competency. And that includes for all clinical and non-clinical hospital staff. It includes your valet parking staff. It includes your maintenance staff. It includes your C-suite executives and individuals on the governing board that are trained and have competencies around patient safety, that they actually know what's important in patient safety and how you can prevent errors. And finally, that the organization has an action plan for workforce safety, because we know workforce safety and workplace violence are major issues as well. Safe patient handling, exposures, sharps injuries, slips, trips, and falls, psychologic safety, especially now, where the morale of many staff in many organizations is sort of at an all-time low. Next one, please. The third is around the culture of safety and really the creation of the learning health system. Here, we ask that the hospital conducts a hospital-wide culture of safety survey. There are a number of tools that are available for free of culture of safety. AHRQ certainly has one. There are others. There are a number of validated instruments. And we ask that a culture of safety survey is conducted across the hospital annually, or it can be every 2 years with some pulse surveys on target units of your choosing. And that these results are, of course, shared back, we're talking about the governing board, and used to inform unit-based interventions. that there is a dedicated team that conducts event analysis. Most of you are very familiar with this, root cause analysis, or fishbone diagrams, or other ways of really conducting systematized event analysis. And that finally there is a patient safety metrics dashboard that uses external benchmarks for safety. You can use the CMS STARS rating, you can use Leapfrog, you can use other national databases to monitor your performance. Continuing on the next slide for domain 3, other requirements include around high reliability, that the hospital has implemented at least 4 of this list of high reliability practices. Now, I'm not going to go through all the high reliability practices, but you have a choice here, and you have to find, are there 4 of them that you're using? Tiered and escalating huddles, if you're not familiar with safety huddles, is a key fundamental principle of all high reliability organizations. And they're really very helpful. We ask here that they're done at least 5 days a week, with one of those days being a weekend. Or that hospital leaders participate in monthly rounding for safety. Or that there's a data infrastructure to measure safety, or technologies that are in place like computerized provider order entry or barcode medication administration systems that promote safety and standardization of care. Many of these things are standard in hospitals already, but the underlying principles of high reliability organizations are really the foundation of organizations being able to achieve those best safety results. I will point to the VA systems here. The Veterans Health Administration hospitals have really done tremendous work when it comes to high reliability organizations. Same for the military hospitals. And if you're looking for some great resources, I think they provide their tools online as well. You can see the rest of the choices here for high reliability organizations, but we're really trying to encourage people to think along the lines and the lessons of industry that we know for high reliability practices. And finally, in trying to create a learning health network, that the hospital has participated in some large-scale learning network for patient safety improvement. Some big systems have their own. Some participate through their patient safety organizations. Some participate through other organizations, the quality improvement organization networks that CMS sponsors. So there are many ways to fulfill this, but we are asking that people are participating in ongoing learning networks. Next slide. In domain 4, accountability and transparency is really so important when it comes to safety. We all have to take accountability, but we have to be able to talk about this in a safe environment, and there has to be transparency. So here, this domain is asking for a confidential safety reporting system that really allows staff and others, and I would include patients here too, to report patient safety events, near misses, precursor events, and prompts a feedback loop to those who report. There's nothing so frustrating as reporting into these various tools and it's like a black box and you never hear back. And so really the ability to have a feedback loop is important here. Voluntarily works with a patient safety organization that is listed by AHRQ. So AHRQ, the Agency for Healthcare Research and Quality, maintains a list of the patient safety organizations of the country. There's about 103 plus. And we ask that you voluntarily are working with them. These are important because they help disseminate information around best practices. They encourage the culture of safety. And finally, in domain 4, that patient safety metrics are tracked and reported to all clinical and non-clinical staff, and that they're made public in hospital units. So for example, they're displayed on a blackboard someplace, or maybe you have a place where you display things so that staff, patients, and families and visitors can actually see how that unit is performing. Next slide. All right, we're into domain 4, continuing that again. There's a defined evidence-based communication resolution program. Let me stop here for a moment. Some of you may be familiar with the CANDOR model. There are a lot of resources for this. You can find them in AHRQ. This is a communication and optimal resolution toolkit called CANDOR. You don't have to use the Candor model, but that the facility should have an evidence-based communication and resolution program which engages patients around safety and harm identification, has open and ongoing communication with patients' families about the harm event, has the event investigation as well as prevention and learning, provides care for the caregiver, because we know that when a harm event occurs, the caregiver is affected as well, provides upfront or at least a conversation around financial and non-financial reconciliation with the family, and patient-family engagement and ongoing support in the event of a significant error. And finally, an accountability and transparency uses standard measures to track the performance of these communication and resolution programs, and back to the leadership, reports them to the governing board. Next slide, please. The fifth domain, the final domain, and I would actually say perhaps the most important domain, is how we're engaging patients and families when it comes to safety. Here, in order to achieve the points for this domain, we're asking that hospitals have an active patient and family advisory council, commonly known as a PFAC. This is really so important to make sure that hospitals are hearing from their patients, certainly in this case around patient safety, but there are many more things to get feedback from patients about. The PFAC needs to include patients and caregivers and are diverse and representative of your population. So you choose, it should reflect your population. Patients have comprehensive access to and are encouraged to view their own medical records. Some people make the electronic medical record available to the patient during the hospitalization. Some people make it available if the patient asks. Certainly, patients not only need to have their medical records that are available to them, and it may be through a patient portal or other options, but to the degree feasible, help patients interpret the information, make sure that what patients are seeing is culturally and linguistically appropriate so that they can understand it, and also make sure that there is a system within your hospital where patients can submit comments about their record for potential correction to their record. Patients read their notes. Open notes is something that many organizations have instituted, and they are a valuable source of being able to provide feedback if there is an error. We also ask that patient and caregiver input is incorporated about patient and safety events. So when there is an analysis of an event that may have occurred, ask the patients and involve them and perhaps offer them an opportunity to get involved. And finally, supporting the presence of patients or family or another designated person as defined by the patient as essential members of the care team and encourage their involvement and engagement, maybe in bedside rounding or in shift reporting or discharge planning, and that visitation excuse me, is as open and flexible as possible. Next slide, and hold on for one moment for me. Sorry about that, I got something stuck in my throat. I spoke already about scoring and performance. So 1 point for each domain. In order to get the point, you have to attest yes to each statement that is in the questionnaire. The scoring is on a 1 to 5 scale so that the possible highest score is 5. There, I saw briefly was a question in chat of why did we do this through NHSN? CMS is working closely with CDC, and many of the safety measures are already reported to NHSN, such as hospital-acquired infections, some of the complications. We like NHSN as a format of reporting. You may see even more of this in the future. NHSN is also working to advance their reporting abilities and will be working on electronic ways of reporting, including through FHIR and FHIR APIs. You'll see that more in the future now. But NHSN serves over 38,000 facilities in the United States for reporting of events, not only around infections, but certainly for safety. Reporting safety through NHSN over time would allow us then to have a standardized national model for reporting of safety. The total score will be public on Care Compare, but again, the total score, and it won't be broken out there by the individual questions. Although patient safety advocates have really asked us to put out all of that information, you can frequently find much more detailed information on the provider data catalog. Next slide. Just a few thoughts on how can you translate this patient safety structural measure into action. Again, a lot of this you can find in the National Action Plan, and there are a few steps to consider the assessment of the National Action Plan that I just want to highlight. First is look at your governance. Is your board, again, your fiduciary board, spending time reviewing safety? Are they assuring appropriate resources? Are they hearing about events in a timely manner? For training, is there a training curriculum? There are a lot of training curriculum that are available, some of it through the National Action Plan, some of it through quality improvement organizations. So some sort of curriculum where people are learning about patient safety. Regarding the culture of safety, are you conducting a culture of safety? And if you do, what do you do with them? What do you do with the results? How are you addressing that and improving? High reliability. Are you familiar with the key principles of high reliability organizations? Have you implemented things like daily huddles throughout your organization or leaders rounding for safety? And finally, what's your dashboard look like? Do you have a dashboard that is shared across your facility, including with your governance structure and the public, that lists your quality and safety metrics, in this particular safety metrics? Are they posted on units? Can patients see? On some units, as you're walking through the unit, you can see things like, days since last central line infection, and things like that. Next. A few other things, data. What are you doing with your data? Many of you, I would say the majority of you, have electronic medical records. How are you using your electronic medical records to proactively identify data, what I would call trigger tools? So I know some hospitals who on their daily safety huddles are looking at whether or not somebody has a femoral line in place, right? Because we know that femoral lines frequently lead to catheter-associated bloodstream infections. So how can you utilize your electronic data to be looking at precursor events in near real time? We spoke about the Candor model already. Evidence shows it reduces malpractice claims when you start talking to patients and seeking their input when there is an error that occurs. We spoke about patient access to records in the Patient and Family Advisory Council, and then ongoing learning. So all of these are ways that you can be translating the patient safety structural measure into your facility. Next slide. This is my final slide, so we will be open for questions after this, but there are some resources here. There's an attestation guide that has been developed to this measure that you can access, and then these are the actual specifications for the measure, so that there is information that is available at CMS sites, information that's available through AHRQ or IHI and the National Action Plan. AHRQ also sponsors a series of webinars around patient safety. You can go to AHRQ's website and find information on those. Those are free for anybody to attend, and they bring forward best practices around patient safety. There are a lot of resources. There is a lot of federal action that has been put in place to support patient safety because we realize that patient safety is one of our most fundamental commitments to our patients. In the Hippocratic Oath, it says, first, do no harm. We really need to be sure that we are first doing no harm. So I thank you really for your participation today. I will be happy to answer questions. I think Kim or Jennifer, you're going to be reading some of the questions, and I will do my best to address them. Thank you all for your participation.
Thank you so much, Dr. Schreiber. I know there are several questions in chat, so I'm going to ask Jen to bring those up in order that we receive them and then continue to, excuse me, to type those in, please.
Yep, absolutely. Our first question, Dr. Schreiber, is to confirm this measure does not apply to inpatient rehab facilities, correct?
Correct.
The second question, can you clarify for the board notification of serious safety events if it is all board members or if it can be a subset of the board members, for example, the chair of the board and the C-suite leaders?
The way this is constructed, it's all board members on that senior governing board. I don't necessarily know that we would object if it were select ones, but the purpose of this is so that your board really sees what is happening with error. And so my answer to that would be, it should be all the members of that senior governing board.
Thank you. This question is related to Domain 2, Section D. What are some examples of how institutions implement patient safety curricula and competencies for both clinical and non-clinical hospital staff? This facility is considering incorporating patient safety training as part of the onboarding orientation for all staff.
I think there are a lot of options here, quite honestly. Onboarding, I think, is great, but I would also kind of say that a one and done, so somebody who's been here 10 years and only got patient safety training the day that they first arrived, probably isn't enough, okay? Lots of people have various, online learning systems, that you have to click through a bunch of slides. I find those generally boring. On the other hand, it would do the job here. And I think some of it has to be targeted towards the people that really do this the most. So I think probably training for unit managers, in some respects, the most important people who are carrying this out, needs to be more extensive than it is for others. So I think this is an opportunity that hospitals and organizations can be creative with how to do this. But the bottom line is that there are many people who really don't understand what patient safety is and don't understand how almost anyone you can think of in a hospital can contribute to patient safety. The valet parkers can help patients so that they're not falling and can identify if they have a need. Housekeeping, we know, is really a form of infection prevention, quite honestly. And when you engage them to feel that way, first it empowers them and it gives them important education. Nursing staff clearly carry this out frequently, so having them understand. The physicians need to understand their role in patient safety, even in things like rounding or timeouts. So everybody really benefits when they understand the goals of patient safety, the metrics of patient safety, and how best to do it.
Thank you. Our next couple questions are on the penalties or the repercussions of not reporting. So if a hospital scores a 2, will there be a reduction in payment?
No. It does not depend on how the hospital scores. The only reduction in payment would occur if you don't report at all. And that's true for any of the measures in the inpatient quality reporting, right? In order to meet the requirements of participating in the inpatient quality reporting program, you have to report the measures in the inpatient quality reporting program. If you report the measures, you pass and there is no financial penalty whatsoever. Even if your score is 0, if you report that, there is no financial penalty whatsoever. But if you fail to report this measure or any other measure that's in the inpatient quality reporting, then there is a penalty, and it's a 2% penalty of your annual payment update.
Thank you.
But the performance is in some things, depending on how you perform, like in readmissions, you can be penalized in the hospital readmission reduction program. I understand that. That is not how this works. You just have to report.
The next question is to confirm hospitals are attesting to our intent to be compliant with the measures in 2025.
You are attesting for the entire year of 2025, and it is not that you have an intent for these. This is that you are doing them. If you have an intent, you haven't done this, you haven't fulfilled the statement. If you have done them, even imperfectly, if you have done them, then you meet the criteria. To be honest with you, I will be very surprised if any hospital actually has a 5 and answers positively to every one of these elements that we were asking. We may showcase some of the hospitals that are 5s. I would be very, very surprised. This was done with the intention of ensuring that there are robust systems that are supporting patient safety, and that these systems, each of these elements really works together to help any organization drive patient safety forward. So we are not expecting perfection. It's just like the pursuit of zero harm. We always have to be working in that direction.
Dr. Schreiber, that's an interesting point there too. I think that's both comforting and from the implementation standpoint, but also is there any consideration perhaps to how this will be described on Care Compare then too, as consumers are looking at that and assuming that everyone should be a 5 if they're not, that
Yeah, thank you thank you for that comment, Kim, and it's an interesting comment. I do think we could perhaps place something on Care Compare saying, first of all, that this is a new measure. We're hoping that, organizations consistently strive to achieve reductions in harm.
I see there's still more questions in chat. Jen, do you want to take those?
Yep, I'm collecting them.
Thank
So
you.
the next question I have is, a lot of these measures are very similar to Leapfrog. Would you consider having a collaboration with Leapfrog?
Oh, I'm very collaborative with Leapfrog, actually. I know them very well. I've been involved with them for many years. We do collaborate with Leapfrog on many occasions. And I think there's a synergy between what Leapfrog is doing and what CMS is actually trying to do. Leapfrog, of course, is the employer community looking for evidence of safety. So we see another opportunity for people being interested in safety. In some of these dovetail with what Leapfrog is asking, and some of it is a little bit different, but we do collaborate with Leapfrog.
Thank you. So the next couple of questions are about what CCNs this applies to. So one hospital has an inpatient psych facility that falls under the CCN, but has a special CCN with a letter added. Would they be included or excluded?
An inpatient psych facility is not required to answer this measure.
And then we have one that we have clinics that share our CCN. Does this apply to them too?
It does not apply to ambulatory facilities at this time.
Next
So
question.
if you have a CCN that includes other facilities, you don't have to survey those other facilities as you answer your question. This really applies to what is happening in your hospital.
Thank you. And then a clarification, the governing board must be fiduciary.
I speak of it as a fiduciary board because that's just the language that I use. It really is the senior governing board for your organization, right? As opposed to a delegated subcommittee like a quality subcommittee of the board. I recognize within big systems, that have hundreds of hospitals in them in some cases, the actual fiduciary board may be at a system level in a city that's remote from where your hospital is, and that may be your fiduciary board. But by the conditions of participation set forward by CMS, every hospital has to have a governing board. And we are referring to who is the governing board of that hospital. I'm not saying system boards shouldn't be accountable to this too. It's just that CMS regulations don't apply to that kind of system. It applies to hospitals.
I see a question in here too, related to domain 5. Some organizations, particularly small critical access hospitals, often engage patients, family members via advisory programs that are outside of the traditional PFAC setup? For example, directly engaging advisors on safety teams, how are they to interpret their compliance within Domain 5?
I would probably, in those particular cases, count that activity towards engagement with patients and families.
Excellent.
And to reiterate, because this has come up several times, this is not required of critical access hospitals. You can choose to. You can choose to report any of the IQR measures, but this is not required.
And I have a few more questions. I see we have a few more minutes. The next question I have is, are there any resources for the development of competency at various levels of the organization? What standards or guidelines say we have met the competency requirement?
That's probably best answered within our guideline document, but is so much information around patient safety that I think you can determine for yourselves what really meets this. Again, there's a lot of information. I would point people to a couple of things in particular. Number one, the Joint Commission obviously has a lot of information around patient safety. Some people use the vendor Press Ganey for their patient experience. They have a lot of things around patient safety. IHI, of course, has things on patient safety. Free to all is AHRQ's information on patient safety. CMS, through their quality improvement organization, has a lot of focus on patient safety. So there's a lot of information, I think, that is out there. There are self-assessment tools included as part of the National Action Plan that people can take. So I think that there is a lot of information that is actually available and a lot of training that is out there as well.
And I will add to that then too, that our team at Convergence is really trying to streamline, take all of those resources together, and that's what we'll be focusing our educational efforts on. That will all be free over the next several months then too. So I hope that you'll join us for that too. Little plug.
That is wonderful. I think the more people can collaborate together on
Exactly.
patient safety and make sure that we all have these vital infrastructures in place to make sure that our safety systems are resilient and that they're serving patients, engaging patients, always, trying to keep our patients safe and our workforce.
I agree. There's one last question in here I think that we have time for. I believe I know the answer to it, but let me just ask, does the PFAC representation, regarding PFAC representation on the board, does that representation have to be a patient or can it be a staff member on the PFAC?
I never was asked that before, but I think it could be any member of the PFAC.
Okay.
I will answer with my personal opinion here,
Mhm.
however. And my personal opinion is it should be a patient because the goal of this is that the board hears through the lens of the patient. But there's nothing that says it can't be any member of the PFAC.
Great. Here, okay. One line. Now I said that was the last question. Here's one more. This is a great one. For cause that are that would voluntarily like to do this, that are Joint Commission accredited, what components of this measure do you suggest they focus on to not only meet accreditation requirements but promote safety? Are there any that stand out for small organizations like that?
I think I think for any organization, the most important one is actually leadership and governance because leadership and governance sets the tone of what is done in any facility. Sometimes I think that's easier in smaller facilities because your leadership and governance. They're people that, there aren't that many staff, so everybody generally knows each other and frequently fills more than one role. But I think it stems from leadership and governance. And then if I had to pick the next most important one, or probably the most important one, although leadership to me is very important, it's engaging the patients. It's making sure that we are listening to our patients, that we are taking into account what is happening to them, that we are including them, that we are talking to them and communicating with them, offering communication and resolution programs to them where it's necessary. How we engage and make sure that our patients are active participants with us, I think is one of the most important features of patient safety.
And with that, that brings us to the top of the hour. What an incredible way to end this session. Dr. Schreiber, thank you so much for joining us. There's lots of chats in there. Wow, this was so helpful. Thank you. I agree. I wholeheartedly agree. And thank you so much. We will send out the slides, the recording. I know there were a couple of questions that it did not get answered. Feel free to just send those to me, to my email, kworkmeister@convergencehealth.org, or you can just reply to the email that goes out with the slides and recording within the next few days here too. And keep joining us. If you're not a member of our listserv, we'll send that link there too. You'll want to join that so you can get notified for other events, other learning opportunities to collaborate with others as we all work together to implement every one of those to all become a 5 at some point here on this patient safety structural measure. So thank you so much, everyone. And as always, thank you for what you do every single day to make care as safe as possible for the patients that you serve and for the environment in which that care is provided as safe as possible for our workforce. So thank you from the bottom of my heart. Have a great day, everyone.
Thank you. Have good holidays.
Thanks.